it's amazing seeing the new BVMs that they're coming out with that only expand, for 6 seconds before you can squeeze it again.
Right.
Why? Because we're overinflating people. Why not develop that? And it just makes sense. It's like, why didn't I think of that? I could have been a millionaire.
You're talking about Pulmodines?
Pulmodines.
So actually, you can turn that off.
You can.
Which
if you
is
want
critical if you have to.
But the fact that it exists now, and it looks like a football too, so when you're done, you can have fun with them. But these are so cool.
To that same point, I mean, Don, when you went to medical school, certainly when I went to medical school, more was better, right?
Yeah.
You fixed people with more of everything, right? More antiarrhythmics, more drugs, more, squeeze, bag harder, bag faster, right? And we've
Well, it's less diagnostic then too. Like I'll go back to your point about you talked about. Well, they have an altered mental status. Okay, well I'll give you Narcan. I'll give you sugar because I don't have a glucometer. I don't have these things to rule it out. So it's
Narcan, Romazicon.
I'm going to start just funneling down my chart, and I'm gonna feed you a bunch of drugs and see if I get a positive change.
Put them into withdrawal, make them combative. Now you got to give them ketamine. Good job.
Good job. But that was it.
And now that's changed. And I think it's evolved, and I think testing's evolved, and the way we teach is evolved to try to be more high fidelity, and that's the real setting. And I'm a firm believer in that. Is if you train the way you train and you train appropriately, then you should perform under pressure that way. So if you're training as a 2-person team or you're testing out as a 2-person team, you're going to go back and forth. Hey, right. I have this, you have this. It's no different than, a trauma patient. We'll use your example. You walk up, you approach on the side of the freeway. Maybe your EMT is, behind you bringing equipment, and you look and you're like, okay, sick, not sick. These are the priorities. This is what I want to do. And, the EMT is going to walk up and collar that patient. We're going to be like, we're going to move. It's that team approach, the back and forth, or, hey, we need a tourniquet over here. I see this bleeding, and I think if we continue to train that way in the way we teach in our organization, I think is key. Yeah. To deliver more of the why. Why do we do this? Why is this important? Why is it important to understand all the values of shock?
But also understand that it's okay to ask why. And we came from a generation where that wasn't okay. If somebody said why, you were just shut up, Roby, and do it. That's why.
Right. Correct.
You got to change. If they ask why, it's because they want to know.
Yes.
Oh yeah.
100%. Sure. 100%. Now I think that's changing. And in our organization, the physicians are so engaged, like Dr. Spanner, Dr. Hill, Dr. Garlisi. I could go on and on. Everyone, Tony, everybody's involved, so that I can come up and say, I don't understand why this went this way. What did I miss? Right. Absolutely. I want to get better, and that's how you recognize. Back to shock. It's you and your partner. Hey, I caught the respirations or this. Okay, I'm working on something else, right? It's a team dynamic, and we want a high-performing team to make early recognition, early treatments, and deliver to definitive care. Right. And that's what's going to save that patient. It kills me, and this is my pet peeve and my soapbox, is sepsis patients. They're septic.
Huh.
They're septic.
Sepsis is your pet peeve, huh?
This is my button. They're septic. Okay, what'd you do? Oh, we gave him some fluid.
We took him to
Their
the
pressure's
hospital.
still low. Really? Like, what was your bolus? We have, you can do push dose epi. Like, why aren't we being aggressive? What's their end title? Like, sepsis has over a 50% mortality rate, and we're dragging ass out there. That's not okay.
You're phoning it in.
I'm sorry.
You're phoning it in.
And it's no different with anaphylaxis. We could change gears and go to another distributive shock. How we need to correct it. We're not pulling the trigger on epi enough.
Well, if someone's going to die from anaphylactic shock, it's from lack of epinephrine. It's not from too much epinephrine. If someone's going to die from septic shock, it's from leaving them in shock for an extended period of time and watching multi-organ failure, cellular and tissue death.
Consume the patient.
And so, because you brought this up, Ray, and I think this is critical, at least in my eyes, one of the things I see in the pre-hospital environment that is disappointing is that you follow the protocol, and the protocol says 20 cc's per kilo of whatever crystalloid if you have the septic patient, okay? And then the next block, because especially the older paramedics are used to being protocol driven. And we have to move away from just the protocol and put your thinking caps on. Yes. So you need to know early, because let's break it down. How many paramedics Yeah, I mean, you guys work in fairly rural areas, okay? So you probably will not answer the same way that, an urban EMS person does. But I'll ask urban EMS folks, how much fluid did you get in that patient? What's the most fluid you got in that patient before you got to the hospital? And they're like 300 cc's, 500 cc's. Mm-hmm. And I know you guys transport longer, so you're gonna get more volume in them. And yet, even the urban ones have 15, 20 minutes before they get to the ER, and they've left that patient 10 minutes on scene, 20 minutes en route, a half hour they were remaining in shock. And instead, why aren't they anticipating? Why aren't they saying, okay, the protocol reads 20 cc's per kilo, well, I'm 100 kilos. Okay, maybe a little more, just whatever, okay? Just make it 100 kilos for math purposes, okay, and maybe make my wife happier.
Good
okay?
reason. Good reason.
But we're going to call me 100 kilos, okay? So using the protocol, that would be 2 liters. Nobody gets 2 liters in me. So are you going to leave me in shock? Or are you going to find out, am I fluid responsive? So how about we put 300 cc's in, check that blood pressure, and if my initial pressure, and I look bad, okay, I was 60/40. I had a heart rate of 130, and you gave me the 2-liter bolus, but you only got 300 cc's in, and all of a sudden my pressure is 86/60. I'm pretty fluid responsive if I'm doing that at 300 cc's. Keep pounding the fluids. But if you do 300 cc's and my 60/40 is now 58/32,
62.
I don't think the additional 1700 cc's is going to do anything. So instead of just walking into the ER and saying, we got 500 and he's still in shock, how about breaking out the push dose epi? And then how about we decrease the mortality?
Yes.
And 100%. By the way,
sorry, that
Scott,
was my rant too. By the way,
what'd you say?
I went on a little rant there. I circled through a couple revenues or a couple venues of shock, and then circled back. So
no, I think that's good. But Scott, why don't you talk about how you train people to give the push dose epi? I think it is magical, and it teaches them that the push dose epi is nothing more than you being a human IV pump, and then looking for that response. Do you mind? Or do you want me to do it?
I don't know what.
Okay, you're the one who showed me this, and you don't even remember.
I clearly have made a point that I
So first of all, you got to understand, guys like me and John, we don't use push dose epi because they give us pumps. And when we first started switching to push dose epi, they said to me, I've always told every paramedic that I've trained, yeah, I'm never going to ask you to do anything that I haven't tried. So did I drive the pharmacy crazy? Okay, so I said, you got to send me a bag of 1 milligram of epinephrine in a 100 cc bag of D5 and just send it to me. And he's like, Doc, we can't do that. And I'm like, you don't understand. I'm going to be asking hundreds of paramedics to do this. Right? And we're doing it only because they don't carry IV pumps. So bear with me. So for 2 weeks, I drove the pharmacy insane. Okay? But it works. And I was talking to Scott about this, and I'm stunned you don't remember this because it's stuck in my head.
I don't remember which.
those.
What Pete? What Pete?
No. What he said to me was, and I'm not trying to put you on the spot on a TV thing, but this really was incredibly helpful for me. You said, Don, you got 10 mics in a CC. That's like blowing air. It doesn't mean anything, And then I think it went like this. But anyway,
this is a true story.
Told you,
true story.
Then he goes, what I tell my medics to do Correct me if you don't remember telling me this. You said what I tell my medics to do is you push that 1 cc. There's no math to this. You put the vial in the bag, you pull out 10 cc's, and you push in a cc, and then press the buttons. He remembers.
Yep, and by the time you get that number back,
it's
already metabolized.
But, but then you actually see what that push dose epi is doing. So if you don't get that MAP of 65, if you don't get that systolic of 90, then you give 2 cc's. And you look for that result. If you don't have that result, as soon as you press that button, you give 3. And our protocol goes up to 50 mics at a time. Yeah. Whatever the response you get that works, that's the dose. That's your IV pump dose, if you will. You are the human IV pump. And I'm sorry to go into a whole rant, but that's how I train my medics on what you said.
But again, that's being a good proactive medic that knows how to use the protocol. And if you box it, you're not going to get that out of this. You're going to read the box that says, 1 to 10 mic, and then you're going to stick to that. But when you actually learn that this is more of a cookbook and not a fairy tale, and that you need to follow the recipes, you can use it correctly.
And I actually have a follow-up to a couple things you said that I really liked is pre-planning ahead is a big thing, right? So we have some nursing homes in our coverage area. And
you probably should probably should just make a bag in the morning.
Some days.
How much do we use? At least 1 milligram a day.
Yeah, once flu season and pneumonia really starts to hit, yes.
Carry a 100 bag in my pocket.
D5.
Don't carry a 100 bag in your pocket.
But I think what you said is key is people, well, I can only get this much fluid in them. Well, why? Why? Get to the root of the why. So if I have my 1 liter bag of saline and I want to give it, what's my drip set?
Your 22 gauge needle with a 60 drip, right?
Correct. So we have to start off with, it starts off with what IV access did you establish? Let's just say we established a 20 or an 18 just to be fair, right? And then what drip set did you pick? Because they're not all created equal. You can't just grab one off the shelf, A lot of people get that confused. We'll have a 10, a 15, a 20. There are no 15s or 20s on our ambulances in our organization. There's only 10s.
Only 10s, same here.
There's only 10s. If you want like a dial-a-flow or a 60 drop drip set, then you better be going into the PED bag, and we don't even use those anymore for burns if you read the protocol. So I know I'm going to get more fluid out of that 10 drop, plus how could I piggyback off of it? Pressure bags, they're really cheap. If you don't have a pressure bag, you have a blood pressure cuff.
You better have a blood pressure cuff.
So we can increase the amount of fluid. So as long as I have a good flow, I can use that blood pressure cuff, pump it up, and really start making it rain to deliver some more fluid on the way to the hospital so I could see if I get a better response. And then I like your prepare for the next thing. You get that patient that's septic, their end tidal is low, they're breathing really high, their blood pressure's in the crapper, and you're looking at them, and I'm trying to give fluid. A lot of times we run double medic squads, and I saw this one time with one of our providers. He's watching the fluid bolus, they're cycling the pressure, it's coming up a little bit, but not enough. He literally, boom, pushes it, mixes the D5, slides it over across the seat, says, I'll start driving, right? How about that? So I'm trying the fluid. I'm getting a little bit of somewhat of a response. Yes. It's slowly improving them, but it's not enough, right? So we're trying to get them out of shock. But hey, that other paramedic just pre-planned and slid you over your push dose epi, and it's like, okay, yeah, I need to move to this. This isn't working.
Teamwork.
That's teamwork. That's preparation. That's pre-planning.
Forward thinking. Yep.
Yeah, 100%.
Somebody that's seeing the opposite happen. Yeah. Somebody who knows what's going to happen if it doesn't.
Yeah, and they're anticipating what you're going to do, and I think that's key. And I truthfully believe we teach that here, and we teach as an organization, we teach that how to think outside the box. You're not baking cookies. This is proactive. There is. It's a dynamic situation every time. It's just not static. I'm going to go and do box A, B, C. We have to anticipate, okay, if box C doesn't work, then, box D is sitting right here. And it takes time to do that. But I was really impressed with that one provider. Mixed the push dose epi, slid it across the seat, because he knew you're going to that. You're going to move to this
knows what's next. Right.
So we're going to jet because this patient's sick.
I love that.
I gave you the football, and it's just things to think about. So I liked a lot of your points there, Dr. Spanik.
2 things I want to add to that. One is I think there's, and you were framing that up as a septic medical patient, and I think there's a natural reluctance in a lot of cases, let's say it is, the case that you suggested. Gave 300. I saw I saw that blood pressure move right in a positive direction.
Right.
I know they're fluid responsive, right? And then to raise part, you can squeeze that in. You can also do that again on the other side. You can put a second line in it, right? If it's not a trauma,
100%.
I think sometimes that doesn't enter our minds. Like, well, we put a single IV in our medical cases. Well, you can put two in if you need to.
Yeah,
that's a good point.
We have IOs,
right?
There's no excuse.
Well, let's use that, right? You only come up with, right? I certainly have had these cases. I only came up with a 22 because that was all I was going to get. Well, put another one or two in, right? Run that multiple times if you need to. The other thing, and I've seen it strike even really, really good providers, is they'll grab the 10-drop set, they'll grab the liter bag, they'll grab the pressure infuser, and then they'll wind up, because they're not paying attention, put a micro bore extension set on, a 16 or an 18 in the patient, and then a micro bore extension set, because there's also this thing that just irks me to my deepest core right now, which is everybody's got to have an extension set or a hep lock or a J loop or whatever you want to term it, but an extension set, the hospital requires it. The hospital doesn't require it. It's a nice thing to do for them, but they don't need it. But if you've got all kinds of pressure, all kinds of fluid, big ass tubing, and
a flow restrictor,
and a big IV catheter, and you've got micro bore tubing stuck in the middle of it, you have a 22 gauge. You have a 22 gauge IV. End of the day, right?
True. Good point.
And
good point.
We had a hospital in our system, not to be named, but it is. That's what they stocked, right? And I was always telling the crews, don't get the extension sets from this hospital, because you're going to back yourself into a corner, right?
Wow.
So pay attention to that little tiny thing, and makes
a good point.
Big difference
really
in your ability to fluid resuscitate these patients. So, what a stupid problem to have, right?
I mean, if we're going that far out of our way just to make the nurses happy, then you should be cleaning your sites with ChloroPrep. That way you can get your anaerobic and aerobic blood cultures off of them before I bring the patient to the ER. Especially if we start doing anything, antibiotic related in the field.
Yeah. The in class when we get to labs and we start doing scenarios, one of the things I'll do is I'll take the J loops, hep locks,
right?
I'll take them out of their kit, right? So they'll start an IV, and then
oh crap, something changed.
I'll watch the whole thing just de-evolve immediately because I don't have a J loop. That tubing still fits that IV catheter, right?
Every class I assign
that is old school. But if you don't have one, or all you have, let's say it is a trauma or somebody you need to volume resuscitate, right?
Yeah.
You have this thing, and yes, I want to be helpful, and yes, I want to make it easy to change that out. But I need a volume resuscitate them. You got to throw that thing away and know that you can screw that right on.
Yep.
I have the same personal. This is Scott's mindset with IOs, right? I go straight to the hub on IOs with my tubing. I don't that extension set that falls out of there. I kick it under the cot.
That's a 90-degree extension.
That's where it belongs underneath. That's where, in my opinion, that's where it belongs.
It is kind of neat.
But
I'm just picking on.
I want that. But you put that valve in between. That's additional flow restriction in my mind. So I take that out of there. Somebody's yelling at me down the line, but did they die? Right?
It's easily correctable though, and it's easy to transition to that. And then we talk about IOs a lot as well. And a shock patient is very open to if you really need to give fluid resuscitation.
100%.
Yeah, I mean the humoral head. I want to say from all the research that I've read, you can go up to 5 to 6 liters an hour. So I mean it's very aggressive on some of these sick patients that are septic. You're unable to establish an IV on, or I use dialysis patients a lot as an example because it's challenging to obtain an IV on them. That's usually fair game right there, and you're going to be able to give any of the medications you're going to need through that site. You can definitely fluid resuscitate them through that site.
Right.
You know, and I think some people are just like, they kind of go back to, well, this is a medical call. I really liked your point there. I can't start 2 IVs. It's a medical call.
Yeah.
We only do that on traumas for some reason.
There's a block, mental block about that.
I only get to drill if it's like a cardiac arrest.
Cardiac arrest,
right? You know, we have all these
major
like
trauma, right?
made up categories of things that just
Made up.
don't
That
happen.
is the
Oh, not too
all
long
exists
ago,
here.
I had a horribly hypovolemic patient who was an adult and weighed about 70 pounds, was not being cared for
This was
by the
I'm
family.
about to say it's
And no access,
failure to thrive.
like
neglect.
a skeleton, if you will. Terribly tragic. I drilled her. Guess what she looked like after a liter of fluid? We had plenty of access.
Right. Pink
You know.
dried up and
Yeah.
And if nobody has had the experience of putting an IO in a conscious or semi-conscious patient, now you should try traditional vascular. I'm not advocating that everybody should get an IO, but if there is that patient like you have described, right, who truly has no access, is in dire need of drugs or
Yes.
and or fluids, right? That's who I'm talking about
I
here.
think they tolerate it better than Andrew got.
But the lidocaine there is,
that's essential.
That's baked into the protocol. But
Yes.
I know that there's been misses on that before, and that I've used that personally. It works very, very well.
Absolutely.
The key there is, as long as you can tolerate to let it dwell in the osseous space, the better your results,
Yes.
right? So if you push the lidocaine in and then push the flush, well, it's
gonna hurt.
It's going to hurt.
Yeah.
But if you can push that and then count to 30, count to 45,
Yeah.
it irritates. It's like you
It's
want to
40
move fast.
milligrams. That's not going to do anything to any adult,
Right.
you know.
Yeah.
From a cardiac standpoint,
Right.
but for numbing works. It has worked very,
Phenomenally.
very, very well for that. So
Yeah, that's a good point.
And I've seen unconscious patients wake up from just pushing fluid.
Yes.
Once IO
Absolutely.
is inserted, and that's got to hurt.
I had a little child do that who was hypoglycemic and needed that immediately and woke up, and you could tell that was uncomfortable.
Oh, yeah.
I think I've told the story. We had a patient that let us intubate them, and then we put the IO in because we were doing it all backwards, and we should really have resuscitated and then intubated. But it was a completely different mindset at the time. Airway was king, right? Airway was first.
Good learning experience.
I can reflect on it now,
Yeah.
right?
Right.
But even at that time,
Well,
I was doing it correctly by the prescription,
by the way it was.
by the prescription. But to your same point, we pushed the flush on the IO, and the dude who just let us intubate him sits straight up on the cot, right? So.
Looked like an
didn't
episode
even
of Bringing Out the
realize.
Dead there.
It very
That was a
much
good-
is
that was a
like-
good example.
That was.
Right?
You could
Classic
have
movie.
that exact that image, right? But
So I'd like to hear you
I
talk a
be
little bit
banging.
about one of the ones that everybody's afraid of, and that's the neurogenic shocks.
Okay.
And I think a lot of people, they get really worried about that one because we're not bleeding anywhere. We don't really see anything other than maybe a line of where the injury might be as far as pink and not. But what can you give us there?
So it's interesting because it kind of depends on where the spinal cord itself is injured. And this certainly is in our distributive shock situations. And it's very amendable to pre-hospital push-dose epi because not only do you see hypotension from vasodilatation, but you see bradycardia from inability to stimulate the myocardium and get the heart really moving. And so I find it to be one of our more fascinating shocks, especially with traumatic spinal cord injury. But you've got to be aggressive. And you recognize somebody, first of all, they're going to be neurologically devastated. So you're going to see the paralysis at whatever level it is. And, I know the pink and all that kind of stuff. That doesn't always work, but certainly seeing males with erections and paralysis and then bradycardia and hypotension is somebody that is in neurogenic shock. And I want you to treat it the same exact way that Scott did with his button pushing for the push dose epi until we can get them on levo and vasopressin and really squeeze them because they do need to be squeezed. I find that the bradycardia is interesting too, but think about the spinal cord. The higher up you are, the more damage you're doing to the ganglia along the spinal cord that house your norepinephrine and epinephrine, that is literally housing it from your adrenal glands. So the only way it can get to them is if it's getting the stimulation required to do that. So if you wipe out the spinal cord, you've now wiped out the ganglia, and so you're not getting, remember, epinephrine has alpha, but it has beta 1. It's going to make the heart beat faster. It has beta 2. It's going to help you breathe better. So all of a sudden you've lost, the stimulation you need from your adrenal glands. And what better drug to use than push-dose epi?
Than epinephrine.
It's just perfect. But, we should... I'm sorry, did you want to say anything else about spinal shock before I cover one other?
No, go ahead.
So the other thing is our anaphylaxis. I always tell paramedics... they don't die on us in the emergency department.
You die on us.
They die on you guys. And so it's you guys that are going to make the difference whether somebody lives or dies in anaphylaxis. And you don't have time to mix up push-dose epi with anaphylactic shock. Somebody without a radial pulse, I don't care if you take your 1 milligram and 1 cc epinephrine and inject 0.3 to 0.5 IM, it's probably not going to do anything. And you can sit there and rub that while you get a line. But that person needs 100 mics at a time. So without mixing anything, your cardiac epinephrine is 1 milligram and 10 cc's, 1,000 micrograms, divide by 10. There's your 100 mics. Just push a cc at a time. As their pressure comes up, what you gave them intermuscularly is kicking in. Because I got to tell you, when I've seen medics do this in the field, first of all, they got to put up with me because I'm going to give them a hell of a hug. I mean, it takes a lot to give somebody that's not dead IV epinephrine, right? And they've done it, and then I just order the epinephrine drip. And then I ordered, the last one I had this on was, can we use names? Orange Fire Department. I'm
Too late now.
Too late, yeah. Sorry. I don't know. But
No, you cannot.
Orange Fire Department had this lady at a local restaurant who told the wait staff that she has a severe shellfish allergy or peanut allergy. It was one of those two. When they're that severe, I think those folks should just stay home, okay? But she consumed this, whatever it was, and dropped. I mean, that's how true the ones that die like that. And another thing I like to say about anaphylaxis is the faster your reaction, the worse it's going to be. Okay? So the Orange Fire is literally across the street. This lady doesn't live if this doesn't work this way.
Correct.
Okay? They went ahead, they started a line, they gave 0.5 of epi twice. This lady was 62 years old. They gave her 0.5 of epi twice IM. Okay? They gave her Salumedrol, they gave her Benadryl, they started fluids. They did everything they could do, but she didn't have a radial pulse. So when she comes in, you can hear the stridor. The stridor was so bad that I ordered racemic epinephrine, and then I gave her 100 mics of epi at a time. Before we could give her the 100 mics, she arrested.
Coded.
And we then are giving her 1 milligram of epinephrine because we're resuscitating her. And we resuscitated this woman. You know this story.
No, but you're making a point that I like to use as a teaching point. But finish your thought.
So we resuscitated her for 20 minutes, and I'll never forget Amanda, one of my very favorite nurses. She says to me, she goes, "Doc, what are we doing here?" And I said, I have taught paramedics for decades that anaphylactic patients that arrive alive don't die in the ER. They die on them in the pre-hospital environment, and this person's not going to die. And she looked at me like I was crazy, and suddenly, on our 5th dose of epi, she comes back. And now she's in tachycardia, big tachycardia. We get the 12 lead, and you can see ST elevation. So then I call the cardiologist, who says, Don, you just gave her 5 milligrams of epinephrine. Could you just let her rest a little? And I was like, okay, but we got an art line in, we got vasopressin going, we got levofed going, and we got epinephrine going. He goes, call me in 10 minutes. And magically, her STEMI's gone.
Right.
Her STEMI's gone.
Little oxygen
and I
deficient
was
there.
like, okay, well, maybe I'm having a STEMI. That was pretty intense.
That was
you know?
intense, right?
She got discharged from the hospital 4 days later. And then, of course, Danny Ellenberger, he's like, we got to invite her to our Heart Heroes dinner. And I go, Danny, I don't want her to eat at our Heart Heroes dinner.
EpiPen's not enough.
We got to start the IV before she comes in.
But there's a lot to take there, okay?
There is a lot, yeah.
They did a good job, but they didn't pull the trigger on the IV epi. That's okay, because they were doing what they could do, and they were right across the street. But I'm telling you, that is the lifesaver. I was on Macedonia, and when we gave it IV, I happened to be teaching that day when one of their street workers, I don't know if that's what they're called, the guys who fix the streets. I don't know. Anyway, sorry.
Yeah, one of the guys that work for the city.
Oh, the city, yeah. And he collapsed, unresponsive, no radial pulse. And I said, get an IV, and their captain got the IV magically. And we did the, epi 1 to 10,000, 1
That was a
milligram
beast thing,
intensity.
right?
It was a beast
I think
thing.
that was, I remember that case, yeah.
And we did the same thing with him, multiple pressures when we got him to the ER. But it was that move in the pre-hospital environment, recognizing that this distributive shock was something that they were going to die from. And it's different because all the other shock classes, cardiogenic shock, hypovolemic shock, obstructive shock, have narrow pulse pressures, okay? But in distributive shock, you're going to see the diastolic away from the systolic, and this widening of the pulse pressure is quite unusual in shock.
Right.
And so when you see that normal or wide pulse pressure, you've got to think resistance decrease. You've got to think distributive shock, and you need to press the patient. So, sorry, you guys keep putting me on these rants.
No, this is
this is
great.
what we
This
want.
is great. This is exactly
really
what we
good.
want to do. And you made a point that it was actually almost verbatim what I've taught people that are having trouble reconciling how I'm using for my non-anaphylactic shock patients. So my distributive shocks, right? Why I'm using 10 mics at a time over here, but over here I'm using 100 mics. And I've used exactly this same words, right? Is, we don't have time. We don't have time to small dose them a bunch of times to get a result because they're gonna die.
Correct.
At which point, what is your dose of epi going to be?
Yes.
They're like, they're in cardiac arrest. I'm like, yes. Well, it's a full milligram then. Exactly. So you see how we have to take
I
this.
love that
we have to
analogy.
take we have to take this big step first.
Yeah.
Because if you don't, right, you're going to end up giving them 1,000 mics anyway. Right? And in your case, it
That's
was
a great point.
5 times over, right? Before, because you were so far behind the 8 ball, right?
Excellent.
But yeah, that's it's funny you said it that way because I've almost verbatim used exactly those points, right?
Yeah.
Just wait. The dose will be a milligram. It's going to be,
Yeah, if you're not aggressive enough, that's what's going to happen.
Right.
And I think
that is not the goal.
no, definitely not.
No challenge to be had here.
No, and I use
I love that.
I use a little bit of a different technique when I'm teaching about distributive shock. I always use a visual aid and say, the person that's stung by this bee, and you think, why am I going to use that in pending arrest dose? Is I have a gallon of milk in a gallon container, and now I rapidly just dump that into a 5-gallon bucket, right? So there's my pipe change, if you will, or my distribution pipe. So if we talk about distributive shock, you get stung by the bee, I get that vasodilation. Now my blood pressure's tanking. We have to tighten that container back up again. But if they have that severe severe allergic reaction, you have to be more aggressive. So for your restaurant story, I like that. That's why we're getting into that. 1 to 10,000, if you will, up to 0.5 milligrams of the cardiac epi to push it, because we need to tighten that container up quickly or they are going to go into arrest, especially if you don't have the radial pulse. We have to treat aggressively to keep them out of that.
So we keep saying that, but that is a very simplistic trigger point for anaphylactic reaction versus anaphylactic shock, right?